Good afternoon, everyone, and welcome to our webinar series on menopause survival course. My name is Brooke Hernandez, Physician Relations Liaison here at the University of Chicago Medicine. The learning objectives for today's webinar will be to review signs and symptoms of perimenopause and menopause, understand available treatment options for menopause-related symptoms, discuss lifestyle interventions for overall well-being in midlife and beyond. I would like to introduce our wonderful speaker for today. We have Dr. Monica Christmas. Dr. Christmas is an overachiever, so bear with me here. She is the director of the Center for Women's Integrated Health. She's also the director of the Menopause program here at the U of C, and she's also the associate medical director for the Menopause Society. So you guys are in good hands. So please have your questions ready if you have any. We will do the Q&A session at the end of the presentation, so please utilize the Q&A feature located at the bottom of your screen. Without further ado, I will turn it over to you, Dr. Christmas.
Great. I'm going to share my screen, and then we'll jump right in. I'm going to leave hopefully enough time at the end for some good Q&A, so you can start to put your questions in the chat if you like to. If you're a brave soul and you want to, unmute yourself, I think, are they allowed to do that, Brooke?
Yes. So you
then you can ask questions directly. But without further ado, I'm going to just jump right in. There we go. So we'll start with just what is menopause? Menopause is the cessation of the menstrual cycle because your ovaries are no longer making the reproductive hormones, estrogen, progesterone, and to some extent testosterone too. Other than testosterone goes down more from an aging perspective, not necessarily because of menopause. Other things that can throw somebody into menopause, we'll talk about them in a minute, but surgical, having ovaries removed, or even other iatrogenic causes like chemotherapy or radiation therapy. Natural menopause happens on average, our median age is about 51 and a half, 52. But the range that 90% of people will fall into is between the ages of 45 and 55. Symptoms, though, and that's defined as not having a period for a full year. And Mother Nature has a cruel sense of humor because I get all the time, people will get like 6 months or even 11 months and 3 days, and they might have a last hurrah period. That can normally happen. The brain is still sending signals to the ovaries to make those hormones. And for the most part, the ovaries are saying, been there, done that, can't do it anymore. But sometimes they'll kick in and you may ovulate or get a cycle. So that's why those irregular bleeding patterns can ensue. But symptoms related to menopause transition can start up to 7 to 10 years before your periods actually stop. The first sign of perimenopause or the first sign of the menopause transition is changes to the menstrual cycle. In the early perimenopause phase, it's usually the periods actually might get heavier, they might get longer, they might get closer together. And in that late perimenopause phase, like right before we're entering into menopause, that's usually when we start to see the menstrual cycle get lighter, get shorter, and start to space out. Why does it happen? As I said, natural menopause just happens because as we get older, our ovaries, I should say we are born with all of the eggs we're ever going to have. And you start to actually lose them even at birth, before birth. But once you hit that reproductive stage of life, after you start getting a menstrual cycle, we are losing an egg every month that you ovulate, but we're not gaining ones back. So once we get to this midlife age range, there's very few follicles or eggs that are left in the ovaries. And the ones that are there, the quantity is low, but the quality is also low, which is why it becomes a little bit more difficult to get pregnant as we get older too. And there's an increased risk of even pregnancies with chromosomal abnormalities. As I said earlier, menopause also can be caused by surgeries that remove the ovaries. As well as chemotherapy or radiation therapy that cause early cessation of ovarian function. What happens after our ovaries are not making hormones anymore? It could be a gamut of symptoms. There is not one menopause syndrome that every single person gets. Some people are really fortunate. They get very few symptoms, if any at all. And then there are other people at the other end of the spectrum that might get all of the symptoms, and they can be extremely disruptive to quality of life, even impacting personal and professional relationships. Um, Symptoms, as I said, can start in that menopause transition or that perimenopause timeframe. It's, I mentioned the menstrual changes, but also the hot flashes, night sweats, sleep disruption, increased anxiety or depression. Some people will say, well, I don't think I feel depressed, but I just don't have energy to do anything. That's called anhedonia, and it's a form of depression that can be very prevalent, specifically in that perimenopause timeframe, and even just feeling irritable or having mood swings. About 40% of people in the perimenopause transition will have mood related symptoms. And if you have a history of having had either anxiety or depression in the past, even if it was just postpartum depression, you have a higher incidence of having mood issues during that perimenopause transition. And it's due to the fluctuation in hormone levels, not the absence. Because once people actually get to menopause where they don't have any hormones anymore, their actual mood gets better. But it's those fluctuations in hormone levels that can increase or trigger those mood-related symptoms. So that perimenopause transition is a vulnerable time period for women. In addition, sometimes with the sleep problems, it really is just related to night sweats. The night sweats are waking people up and then they have difficulty going back to sleep. But sometimes it's not even related to that. Sleep difficulties are more pronounced as we get older, but more so for women in this menopause time frame. Generalized joint pains, weight gain, vaginal dryness. The vaginal dryness can lead to pain or bleeding with intercourse. Even urinary symptoms like urgency, frequency, recurrent urinary tract infections can be due to the menopause transition. There are estrogen receptors all over our body, and when our ovaries no longer make those hormones anymore, the vaginal tissues can change. The tissues themselves become drier, they become thinner, the vaginal canal can shorten. So management, there is treatment for it. So before I'm saying all these things, people might hang up from the call thinking this is horrible, but there is help. Thinning hair, changes to the skin, even dry skin, brain fog is a big one, and then palpitations or even feeling like your heart is racing too, are common symptoms that people can describe in the perimenopause transition and leading into menopause. I'm going to talk a lot about various treatment options. I'm going to start with lifestyle modifications because we only get one body. And one of the things that people always seem to come in with is they almost want that magic jelly bean. And there's not one magic treatment that's going to be a cure-all for everything. And mainly because menopause is inextricably tied to the aging process. It's hard to disentangle sometimes what is truly due to our ovaries not making estrogen anymore versus what's due to the aging process. And I don't have a magic pill. I guess I would take it myself if we had it. So the first place to start, because people that, having done this for over 20 years now, people that fare very well during the menopause transition are being extremely intentional about what they choose to fuel their bodies with. And they are very meticulous about how they exercise not only their bodies, but their mind too. So as we think about treatment, I'm going to talk about lifestyle interventions, mind-body therapies. We'll talk a little bit about non-prescription options, and then prescription options. They'll be broken into hormone therapy and non-hormone therapy. So starting with the lifestyle modifications, the author Michael Pollan, in his book In Defense of Food, had this beautiful quote that I usually put in most of my lectures because it's really accurate, and I tell it to my patients all the time too. But he says, you should eat real food, not too much, and mostly plants. And it's accurate. You know, I'm not saying that everybody has to be a vegan or a vegetarian, but having a plant-forward diet is really helpful, especially because we start to have metabolism changes during this midlife that's really pronounced a couple of years before the period stops and for a couple of years afterwards. So there's about a 4 to 5 year window where people can notice a substantial amount of time, a substantial amount of weight in a short period of time. I've had patients tell me, Doc, I feel like I went to sleep and I woke up and I was 20 pounds heavier. And I believe them. Some of it is due to, as we get to this midlife phase, we are a little bit more sedentary and less active. But there are some true metabolism changes that actually aren't responsive to hormone therapy. So the hormone therapy really shouldn't make you gain weight, but it's not going to make you lose weight. The American Heart Association, these are the guidelines that I've put up here, recommend that we get 150 minutes of moderate to intense physical activity a week, and 2 of those days should be muscle strengthening. At midlife, we are losing more muscle tone, and that muscle is replaced by fatty tissue. Much of that fat deposits in our midsection. I can't think of a worse place for it to go. For worst place from a vanity perspective, but also from a health perspective. In addition, there's evidence that women that carry or that are in that obesity range are likely to report more severe or frequent hot flashes than people of a normal weight. Weight loss has also been shown to help decrease the symptom severity of hot flashes too. Sleep is a big factor too, because if you're not getting enough sleep, we don't have any energy, right? If I'm tired, I'm not going to have energy to exercise. But also there's a lot of evidence that shows that sleep deprivation also affects our food preferences. We have more cravings for higher carb foods or higher calorie foods. So just making sure that we are optimizing sleep can be extremely helpful for a lot of things. And we'll talk a little bit more about some of the sleep hygiene issues. Actually, I'll go back for a second. So although this is the lifestyle modification thing, not our sleep slide, but one of the things that I find, a patient told me this earlier today. She told me, when I wake up, I'll just kind of look. I said, well, what do you do? She said, well, I look at my phone and I'll look at TikTok or I look at Instagram. Sometimes I'll check emails. And that is absolutely the worst thing that we can do, is to look at a tablet or a phone, or even falling asleep with the television on. The LED lighting actually wakes up our wake centers in our brain, and it wakes us up more. So really, if you truly can't fall back asleep, getting up and reading a book or print is a better way, because it fatigues your eyes, and usually within a few minutes you feel tired and you can go back to sleep. It doesn't excuse the fact that you woke up. Nobody wants to do that, but at least you're able to go back to sleep. Falling asleep with music on or even the television on in the background actually increases poor quality sleep too, because your brain is hearing those things in the background, and it makes it harder to have, it keeps you in a more of a lighter sleep than if you didn't have those things on. 2 mind-body therapies that have been shown to be effective in reducing hot flashes and night sweats, as well as helping with sleep and reducing anxiety too. One is cognitive behavioral therapy, and the other is clinical hypnosis. And both of those have been found to be effective for all 3 of those things. Again, minimizing the severity and frequency of vasomotor symptoms or the bother associated with them, improving sleep issues like insomnia, as well as anxiety and depression. In randomized controlled trials, it's been shown to be effective. A big part of it is because many of these pathways or these symptoms are related to central nervous system and just feeling stressed or in a higher state of stress. And if we can do things to help relax our central nervous system, that actually can help these symptoms. So moving into prescription versus non-prescription things. So It really depends on what we are treating. Again, I said earlier that there's not one magic pill that often takes care of everything. Sometimes we really do have to use a multimodal approach where we kind of address the specific symptoms that you're having, and it may take more than one thing or more than one approach. Treatment of hot flashes and night sweats, otherwise called vasomotor symptoms. There's in this slide specifically about prescription options, but there are non-hormonal medications that have been shown to have some efficacy in minimizing hot flashes and night sweats. It doesn't make them go away 100%, but there can be up to a 60% reduction in the frequency and severity of hot flashes by using these medications. The two that are FDA approved for minimizing hot flashes is the last one, fezolinetant. The brand name is Veozah. There are a ton of commercials on the airway about Veozah right now. It's a newer medication that was recently approved by the FDA in May of 2023, so a little over a year. It used to be that we blamed all of the hot flashes and night sweats on decreased estrogen. Somehow that decreased estrogen threw off our body's ability to regulate our temperature, and small increases in temperature resulted in extreme response in our bodies, where we would have this extreme flushing of heat. Usually it's from the nipple line up, followed by sweating or this cool sweat, and then most of us feel cold after that. Why some people get hot flashes and other people don't, especially because all people that go through menopause are going to have no estrogen, but not everybody gets hot flashes and night sweats, and not everybody that gets them has them at the same severity or for the same duration. So this new drug, fezolinetant, or Veozah as the brand name is, actually what we found out is when our ovaries stop making estrogen, our brain sends a signal to release these other neurotransmitters called the candy neurons. And it's actually these candy neurons that may have an even greater impact on our thermoregulatory center. So we can either give somebody estrogen to block the release of those candy neurons, or we can block the candy neurons with this new medication, fezolinetant. It's called an NK3 receptor antagonist. So it's been a game changer because there are a number of people that either don't want to be on hormone therapy or they can't be on hormone therapy because they have contraindications. So that medication can be helpful, and it is FDA approved for that indication. Brisdell is an antidepressant that also has FDA approval for minimizing the severity and frequency of hot flashes and night sweats. Even though that's the only one that has FDA approval, there are other antidepressants that in randomized controlled trials have also shown to be efficacious in minimizing hot flashes and night sweats too. The other two medications that I have on there, one is called gabapentin. It's a neurologic agent that we use a lot for chronic pain syndromes like fibromyalgia or even multiple sclerosis. Gabapentin also has been found to help minimize hot flashes and night sweats up to about 60%. So again, it's not 100%, but it also can help with sleep as well. And then lastly, oxybutynin is a medicine that we use for overactive bladder. So, like urinary frequency, urgency, urinary incontinence. It can actually has been found in trials to minimize hot flashes by about 70%. So if somebody is having urinary symptoms as well as debilitating hot flashes and night sweats, it may be a good option. It does come with some side effects. So dry mouth, dry eyes, constipation. So if you don't have any urinary symptoms, the side effects from the medication might actually be worse than the actual hot flashes. So we always want to consider that too. Hormone therapy options is estrogen therapy and estrogen and progesterone. If you've had a hysterectomy and you don't have a uterus, you don't need any progesterone. We would just give you estrogen. There are lots of ways to give systemic dose estrogen. It can be given as an oral pill that you take daily, a transdermal patch that depending on which one you use, there's a weekly patch or a week patch that gets changed twice a week. There are emulsions, or like a gel and a spray that gets rubbed into the skin. Those are daily administrations. And then there's a ring that's pretty nifty, because the ring goes in the vagina. It stays in place for 90 days or 3 months. At the end of 3 months, you pull it out, throw it away, and then put another one in. But it actually has high enough systemic absorption that it does help minimize hot flashes and night sweats. If you still have a uterus, giving you estrogen can cause the lining of the uterus to thicken. And over time, if you're not shedding that lining, it can increase your risk of a uterine or endometrial cancer. So we give progesterone to help thin out the lining so that we stabilize it and minimize the risk of developing that endometrial cancer in the future. There are combination options for estrogen and progesterone. There's a combination pill where both estrogen and progesterone are in one pill together. There's also a transdermal patch that has both the estrogen and progesterone in it. The issue, though, is that there are not a lot of dosages. So if we give you one of those combination options, and we find that we either need to go down on the estrogen, or maybe you need to go up on the estrogen, then we've got to separate them out, because there's lots of options, as I shared, for estrogen. Not only lots of options, but lots of dosages too. We don't have as many options when we put them together. When we separate them out, we then we can either give you the progesterone as a pill that you take daily, or my favorite thing to do is to put in a progesterone IUD like Mirena, because the IUD goes in the uterus. It can sit there for 8 years. You're not aware that it's there. Your partner isn't aware that it's there. And it works great for protecting the endometrial lining. And then, although I don't have it on here, there is one pill that's a combination pill that's both estrogen and something called a SERM, a selective estrogen receptor modulator. That SERM actually has the same function that progesterone does, and it works really nice. Sometimes with estrogen and progesterone, people can get some breakthrough bleeding. And if there was one good thing about menopause, it's not getting a period anymore. So I try to, use options where we minimize the risk of breakthrough bleeding. That pill that's a combination of estrogen and the SERM, it's called Duovi, actually has a very low breakthrough bleeding profile. So sometimes patients really like that. What hasn't been proven to work? And you see this big, long list. And some of you may be thinking, oh, but wait a minute, vitamin E is good for other things, or how could acupuncture be bad? Acupuncture is good for a lot of things too. And just because it's on this list doesn't mean it's not good for other things. It just hasn't been proven to work for reducing hot flashes and night sweats. Menopause has become actually $600 billion industry. There was an article on the front page of Fortune magazine a couple years ago that actually said that. It was the caption, or the headline was, "Menopause is a $600 billion industry." So everybody is trying to capitalize and make some money off of menopause. So they're either trying to sell something, or a product, or they're selling themselves, or promoting their book, or whatever the thing is. But there are a lot of products out here that are claiming to do things that they actually haven't been proven to do. Many of the none of the herbal supplements actually have to undergo the same scrutiny of getting FDA approved that other prescription drugs have to go through. So people can really make claims about anything that aren't necessarily accurate. There are some randomized control trials where researchers have looked at whether or not these herbal things by themselves or in combination work, and they haven't been shown to be better than placebo. So for example, if you give half the people the herbal thing and you give the other half of the people a sugar pill, what happens is they all actually say, and at the same statistical significance, not everybody does, but about 30 to 40% of people will say they feel better at the same statistical significance. And then after a few weeks, nobody feels better. So we call that placebo effect. So although I have these things on here, some of them might be good for other things, there's not enough evidence behind them to say that they actually work for minimizing hot flashes and night sweats. I mentioned earlier that there are some pretty pronounced structural changes that can happen to the vaginal tissue after we go through menopause. And just like vasomotor symptoms, those hot flashes and night sweats, not everybody will get them. But if you do, unlike hot flashes and night sweats that tend to get better over time, for about 90% of people, hot flashes and night sweats will go away even if we don't treat them at all. The problem is with the hot flashes and night sweats is that they could last for a long time. They could last for, from the moment they start in the perimenopause to when they end, it could be about 7 years. And for Black women like myself, we get them from a little bit longer time frame. It could be 10 or more years. There's a small percentage of people, about 10% of the population. My poor mom happens to be one of those people that will have hot flashes forever, though. But again, that's a small percentage of people. But with these vaginal symptoms, the vaginal and bladder symptoms, they're actually quite the opposite, meaning that if we don't treat it, it's unlikely that the symptoms will get better. And there's a chance that the longer we let those symptoms go on, that it could get worse over time. And what are the symptoms again? I mentioned them earlier, but I mentioned it again. It's vaginal dryness, which could be described as itching or irritation. Some people tell me use burning to describe it. A lot of people will think they keep getting a yeast infection, or I keep getting bacterial vaginosis, and they'll go purchase like an over-the-counter treatment, and they'll put that cream in, they'll feel better for a little bit, and then the symptoms come back. The reality is that they probably don't have a yeast infection, or you don't have bacterial vaginosis. And the reason that you feel better for a couple of days after using the cream is because the cream is moisturizing. What you have is more vaginal atrophy from thinning of the vaginal tissue. And so how we can treat that is either with a vaginal moisturizer or a lubricant. Those are over the counter. All are not created equal. Many of the over-the-counter products have a high alcohol content, or they have fragrances in them, or preservatives that can be irritating to the vaginal wall. So when you're looking for products, we want to get things that don't have a high alcohol content or don't have many preservatives or fragrance in them. Hyaluronic acid-based moisturizers tend to work very well, and a moisturizer can be used regardless of whether you're sexually active or not. It is exactly what it sounds like. It's just moisturizer for the vagina. You need to use it at least 3 times a week. You could use it more, but you should use it at least 3 times a week for it to be effective. It's kind of like lotion for your skin. If I put it on today and I don't put lotion on again until next week, it won't work very well. But if I use it on a more frequent basis, then my skin will feel much better. A lubricant, though, is something that you use just with sexual activity to minimize the friction with insertion of a penis or a toy. You can put the lubricant directly on the vaginal walls or penis or toy to help minimize friction with insertion. Water-based lubricants work very well, although they dry out fast, and so you may have to reapply. Silicone-based lubricants don't dry out as fast, but they have a tacky, sticky feel and may stain sheets, and so sometimes people don't like that. When we're moving into prescription options, so if it's, if you try the lubricant or try the moisturizer and it doesn't work, then prescription options are needed. We can do low-dose local vaginal estrogen therapy, and unlike the treatment for hot flashes and night sweats, this isn't going to be absorbed into the bloodstream. This is only going to be acting at the level of the vaginal walls. So for people that have contraindications to systemic hormone therapy, many can still use local low-dose vaginal estrogen therapy. There's a cream option, a pill option, or an insert that go into the vagina. Those 3 options are applied twice a week at night before you go to bed. There is a low-dose vaginal ring like that other ring I described for the hot flashes and night sweats. This one is much lower dose, so it won't help the hot flashes and night sweats, but it will help vaginal symptoms. And again, just like that other ring, you put it in every 90 days, or you put it in, it can stay in place for 90 days. At the end of 90 days, you pull it out, throw it away, and then put another one in. There are 2 other non-estrogen options. One is a steroid or DHEA suppository. It breaks down into a phytoestrogen and testosterone. Again, it's just being absorbed at the level of the vaginal tissue, not a systemic absorption. And then there's an oral pill called Aspina, which is also a SERM, like the other one I talked about earlier, a selective estrogen receptor modulator. And it's an oral pill that you take daily that can help with the vaginal dryness and associated pain with intercourse. Those options, too, often need to be taken forever. They're not short-term therapies, because as soon as you stop taking it, the symptoms may recur. Moving on to think about sexual dysfunction, because one of the things that happens if especially with vaginal dryness or pain, if we anticipate something being painful, nobody wants to engage, and that can result in more decreased libido. If the issue is truly just due to the underlying vaginal atrophy, then just managing with one of the medications that I just described will help. If though, especially if the pain had been going on for a while, what happens is that we contract. It's just like if you thought that a heavy book was going to fall on your foot, you would tense up and pull your foot away. Our vaginal muscles are no different. If we have been used to having pain and your body starts to tense up, it almost clenches and makes those vaginal muscles super strong. They can feel like it's a barricade. Some people will think, I think I have a vaginal mass because, nothing can penetrate. And it's usually that those muscles are so contracted down that it's hard to have anything penetrate. In that case, pelvic floor physical therapy can be really helpful in relearning how to relax the pelvic floor, and it's not always intuitive. If though we've dealt with there's no pain anymore, it really is that I just have decreased libido. I have just no sex drive. Once I'm in the act, I'm okay, but I just don't want it. I don't initiate it, and that's impacting my relationship as well. Then management with, I put, is testosterone okay? And we can use off-label testosterone in postmenopausal women that just have decreased libido. And some people it helps. In pellets or injectables are not recommended because it can result in super high level or physiologic levels of testosterone in the bloodstream that can have some pretty significant bad side effects to them. But using just a very small amount, like a 1/10 of the dose that we would give a man that gets rubbed into the skin, can actually help. Because there are no FDA-approved options for women, we're using it off-label, and it does have to come from a compounding pharmacy, and insurance most likely will not cover it. Indications for using hormone therapy, right? So the 4 indications for hormone therapy use is moderate to severe hot flashes and night sweats, moderate to severe genital urinary, so the vaginal and bladder symptoms that we just finished talking about, going into premature or early menopause earlier than the age of 45. And that is because people that go into early menopause have a higher associated risk of developing osteoporosis. There's a higher associated risk of cardiovascular or heart disease, as well as cognitive decline. And in young people, especially if it's under the age of 40, there's some evidence that shows that being on hormone therapy, systemic hormone therapy, can help minimize those risks. It's not true of women that go through menopause at the normal age range. Actually, the data doesn't show that it minimizes cardiovascular disease. And in fact, in people over the age of 60, it can increase the risk of cardiovascular disease, as well as there's an increased associated risk of cognitive decline. So although in younger people under the age of 40, there's some benefit in minimizing those things, and those individuals should be on hormone therapy, women of normal age are going through menopause, we don't see those same benefits. The other option that for using hormone therapy is in prevention of osteoporosis, not treatment of osteoporosis, but prevention. Contraindication. So who should not be on hormone therapy? Anybody that has a history of a hormone-derived cancer, like a breast cancer, some ovarian cancers, or even certain uterine cancers. History of having a blood clot, like a deep vein thrombosis or a pulmonary embolism in the lungs. history of liver dysfunction, and any history of cardiovascular disease, or people that we should try non-hormone options in. When is the best time to start hormone therapy? It's best to start it within the initial 10 years of the onset of menopause or before the age of 60. And that is because, as I just said, over the age of 60, the associated risks go up. Local low-dose vaginal estrogen, though, can be started at any time, and it can be continued for as long as you need to use it. Mood symptoms I mentioned earlier. So as I shared, about 40% of people in the perimenopause transition will have mood-related symptoms that could be described as irritability, sadness, that anhedonia that I mentioned, just not having energy, feeling tired all the time. And as I said, if you have a history of having had anxiety or depression, even if you've been stable for many years, the incidence can go up during that perimenopause or menopause transition. Once you're actually in menopause, and if you're still having anxiety or depression, it's usually not a hormone-related thing. That may just be true depression or anxiety. In that perimenopause transition, we can think about using either hormonal birth control for managing symptoms or a trial of hormone therapy. However, hormones are not the first-line treatment for mood symptoms. And if those symptoms don't improve after starting either that low-dose birth control or the hormone therapy, then other options would need to be. So psychotherapy, maybe an antidepressant that's good for anxiety or depression, or even lifestyle modifications. We feel better when we exercise. Those natural happy endorphins are released, and that's why people talk about that euphoric feeling when they work out or they run. During the perimenopause timeframe, like I said, though, during that vulnerable window, even if we do treat with a mood stabilizer and antidepressant, oftentimes we only need a small dose. We don't usually have to give a high dose before people say, oh my goodness, I feel like myself again. I mentioned a little bit about sleep problems. As we get older, sleep issues happen even in men. Our sleep quality just changes. However, when the symptoms are truly disruptive and impacting quality of life, we should be managing them. Hormone therapy is not a treatment for sleep disorders. However, progesterone, certain progesterone, prometrium to be exact, has a sleepy side effect to it. And so often patients really love that prometrium because they'll say, oh my goodness, I'm sleeping like a baby again. The only downside is that for some people, it makes them feel sleepy during the daytime too. And so that can be problematic. There's certain antidepressants that also help with sleep, and especially if there's an anxiety component where I'm just perseverating or thinking about things and I can't get those thoughts out of my mind. They're very intrusive. Regular exercise can help, and then sleep hygiene, keeping the room cool, cotton sleepwear, cotton breathable sheets, keeping the room dark. Not leaving the television on, like I said, while you're sleeping, or music in the background. When you do wake up, don't look at your tablet or your phone. The other thing that can be very disruptive too is that when we use our, now, especially with a lot of people working from home, sometimes their office is in their bedroom serves for a lot of purposes. It's a bedroom, but it's the office. Trying, if you can, to just think about, and this gets into the cognitive behavioral aspect of things, of using the bedroom just for sleep and sex. Sometimes trains our minds to really, just hitting that bedroom to realize that, oh, I'm supposed to relax and go to sleep. I'll last end with, I find a big amount of time is that there's sleep apnea going on, underlying, causing the sleep disruption. And so for women, especially, our how sleep apnea manifests may be different than how it does for men. So if there's any snoring or if there are multiple times people are waking up, I always will get a sleep study, and I can't tell you how many times underlying sleep apnea is a cause, and just managing the sleep apnea can restore sleep quality. And then lastly, I'm going to end on hair loss. Hair loss can be fairly common after menopause or during menopause. Sometimes it's related to genetics too, though, and not just decrease in hormones. Stress is a huge factor in hair loss too, and often we don't experience the hair loss exactly when you're undergoing the stress. It could happen months later. There are other things, sometimes our hairstyling techniques or practices and nutritional deficiencies can also have an impact on hair loss. Hormone therapy does not actually help with hair loss. It doesn't make you have hair loss either. But if you're having significant hair loss, actually seeing a dermatologist that specializes in hair loss can be very helpful, so that we make sure that we're evaluating for other potential causes. And treatment often early can help, not only help reduce the amount of shedding, but it can actually stimulate new follicles or hair growth. So lastly, I'm going to put up, this is our website for the University of Chicago Center for Women's Integrated Health. There is a section on actually specific menopause that shares a lot of the information that I spoke about today, as well as a question and answer section for most commonly asked questions, some tips for weight management during this transition period too, but it's a great resource to use. And then lastly, before we hit the Q&A, I like this quote by actress Nia Long. She says, "We should talk about things for anti-aging, but not where it's like, I want to be young forever. Let's remove anti-aging and talk about what you can put into your body to preserve your quality of life." And I think that is so important, which is why I started the conversation talking about lifestyle modifications. So I'm going to end it here. I'm going to stop sharing my screen. And did we have any questions, Brooke? I wasn't looking at the Q&A. Yeah.
Well, thank you so much. That's so much great information, very helpful. And we do have quite a few questions that have come through.
Perfect.
I will run them by you now. Please feel free as you think of your questions, please put them in the Q&A section located at the bottom of your screen, and we will get to all of those questions in this time. The first question, I have an IUD that stopped my period. How will I know when I'm experiencing perimenopause or menopause?
Great question. So, as I said, some people don't have symptoms at all, and I'm going to hope and wish that for you. But because you're not getting a period, it'll be hard to define exactly when you cross over into that menopause transition. But we would just really pay attention to your symptoms. If you're starting to have hot flashes or night sweats, if you're having any mood changes like we talked about, those would be the big ones. And then at that point, we still wouldn't need to take out your IUD. It's beautiful that you've got that progestin IUD in, because as I said earlier, it's protecting the endometrial lining. All we'd need to do is give you some estrogen. But if you're completely asymptomatic and not bothered by anything, there's nothing else to do. And that IUD can stay in for 8 years. I don't know how old the person is, though. So let's say, for example, when it's time for your IUD to come out, you are 48, right? And so at that point, patients will ask me, well, what should I do? We can do some, once the IUD is removed, we could see if your period comes back. We can do some, and I didn't mention hormonal testing is really not necessary, except for a case like this when you're trying to figure out maybe if somebody's menopausal, because you might want to get a second IUD. I think that's a good time to say, hey, if you're not, we could just put another IUD in, and certainly 8 years from then you would be in menopause.
Great. Okay, next question. Will a replay of this webinar be available later? Yes, we actually decided to record this one. We didn't record the sexual dysfunction one just in case people got embarrassed, because some people asked live questions. So we have recorded this one. So I will send it out to all of the registrants as well as those that weren't able to attend, but they still registered, so you can get this information as well. So yeah, to answer your question. The other one, are there side effects with hormone therapy?
Great question. So for low dose local vaginal estrogen therapy, Not very many, again, because again, it's just acting at the level of the vaginal tissue. However, if one has had the vaginal dryness or the atrophy for a long time, so let's say you went through menopause at age 51, you're coming in now at age 66, so you went through menopause more than 15 years ago, and the vaginal dryness has just been progressively getting worse over time, those tissues are probably really dry or very atrophic. And so when we first start the local vaginal estrogen therapy, you may have some, vaginal tenderness or tingling or pain sensation. And I usually will tell people with that, just not bear through it. We can maybe, instead of using it twice a week, you can use it once a week. Sometimes that's why it's nice to use a ring instead, because the ring is just like a low dose steady state, so we can minimize that. Some people early on will notice that they have more of a discharge, especially because the tissues have been dry for a long time and you didn't have any discharge. So it might feel new, but those aren't anything, it's not wrong, right? It's not a bad thing. And it does go away to the point where you don't even know that it's there. For systemic hormone therapy, it's a little different though, because it is absorbed into the bloodstream. It's a much higher dose. So although it's helping get rid of those pesky hot flashes and night sweats, you might start to notice more breast tenderness, a little more bloating in the midsection. Sometimes, especially because of the progesterone aspect, can have an increase in acne that sometimes happens on the chest or back. Those things tend to be short-lived, and sometimes we can tweak some of the dosages to make it better if those side effects are troubling.
Great. Okay. If one already has depression and anxiety, are they exacerbated by menopause?
And that menopause transition, it can be. And I think it's really important that we talk about that aspect, especially when people aren't feeling bad, to let them know that it might happen. For some people, it may not mean that we have to, change medication if they're already on it, or if they're not on it and just, undergoing, say, therapy with a psychologist. But it might just be a time frame to be more aware and do more self-care, making sure that you're exercising regularly, doing all those things that are helpful, that help boost our mood. But it is a time frame that if you are on a medication and all of a sudden it's not working as well, we may need to go up on the medication. If you're also having other symptoms like the hot flashes and night sweats, maybe we add hormone therapy to what you're taking to see if it helps your symptoms. If you're in that, because these things typically happen during the perimenopause transition where people are still getting a period, using hormone therapy and perimenopause actually can make bleeding worse, because hormone therapy is just getting you up to a physiologic level. If your ovaries in perimenopause are still making some hormone, which is why you're still getting a period. So sometimes adding hormone therapy can make bleeding worse. That's why that IUD, the Mirena, can be really helpful, because the IUD stops the periods from happening. And if you're still having symptoms, we can just add a little estrogen, or using birth control, like a low-dose birth control pill continuously so you don't get a period at all, can be really helpful in stabilizing mood too.
Great. Okay, another question about the anxiety and depression. Any studies on cannabis or CBD for those particular things if you don't want to take like a prescription drug?
Yeah. Um, there's not a lot, so I'll start there. There's not a lot of randomized controlled trials, because the problem is if you have a small study that only has 20 people in it or less, and you give all of them I don't know, the cannabis gummies or whatever, then you don't have that placebo to see if it really works. Because remember, I told you, like most times and most things, 30% of people are going to say they feel better, even if all they got was just a regular old sugar gummy, right? So to really know if something really works, which is why when you get a drug approved through the FDA, you've got to have those randomized controlled trials where half the people get it and other half people don't. Although cannabis can make some people feel more relaxed, it can also create more paranoia feelings in some people too. And there's a tolerance that's built too. So even sometimes if you're starting to feel more relaxed, then it can wear, the effect can wear off. So people then take more, and you get into this cycle, and you're taking more. And then one of the other things that can happen, people think about, oh, the munchies with cannabis, but also it can create a nausea syndrome and vomiting. And my colleagues in the emergency room have started to see a much bigger uptick on that with the legalization of people coming in with this acute nausea, vomiting that's related to the cannabis that they're using. So to answer your question, no, there's not a lot that says that actually should be used for managing anxiety and depression. I know a lot of people use it for that. It's almost like people that say, well, I have a glass of wine to help me relax. In the moment it might help, but then there's some after effects that actually exacerbate the feelings.
Great. Okay. Are the pellets a good option for hormone replacement therapy?
Every professional organization, from the American College of Obstetricians and Gynecologists to the Menopause Society, every other country's menopause society, so the Canadians, the Australians, even the Endocrine Society, have come out with warning statements against the use of pellet therapy. So no, you should not. The FDA has a warning. One, they are not FDA approved. They have not had to undergo the stringent guideline or rigor of getting it approved for safety and efficacy. The other thing is that they give you super physiologic levels. And so that's not always a good thing either, because that can increase your risk of having a blood clot, or that could lead to a stroke. They make claims that because they are bioidentical just means that the molecular structure of the hormone is similar or exact to what, it's not exact, but it's similar to what your ovaries make. And so there's claims that because of that, that it's safer. It is not safer than traditional hormones. And there actually are bioidenticals that are hormone options that are approved by the FDA. The rings that I talked about are bioidenticals. The estradiol in the patch is a bioidentical. There's a bioidentical progesterone. So for somebody that really does want a bioidentical, then there are FDA approved ones. But pellet therapy, it should be a non. And there's some ethical issue with that, because most of these providers that are administering pellets, one, are not telling people that they aren't FDA approved. The other issue with it, though, too, is that you're paying for it out of pocket. It's not, because it's not FDA approved, insurance doesn't cover it. Pellets cost about anywhere from $400 to $600 a pellet. You've got to get it every 3 to 4 months. And I find that as an ethical issue, that somebody that's administering it isn't explaining those things and is making money off of it. So no pellets.
Okay. I am 51. For the last 10 years, I have found that I get really hot and sweaty much more easily than I used to. I did gain about 30 pounds in the last 10 years. I am wondering if this is related to weight gain or menopause.
Probably both. Yeah. So it sounds like I didn't hear that the periods have stopped. So if your periods haven't stopped, you're definitely at that perimenopausal age range at 51. Our metabolism starts to change, and what we were able to get away with in our younger years in terms of exercise or eating, because people say, well, I'm not doing anything different. It doesn't matter. We have to work a little bit harder at it. Weight resistance exercises are going to be really important. So if you have to, cardio is good, but if you've got to pick one, get some weight resistance stuff in. But really just trying to incorporate movement into your day-to-day life. I try to park at the back of the parking lot, even if there's a closer spot, so that I get those steps in. I take the long way around in the hospital so I can get some extra steps in. I try never to look at the elevator. I try to always take the steps unless I'm rushing to get to a patient for an emergency. But even if I'm on the ground floor and I've got to go to 8, I might be a little sweaty when I get to the top, but I take the steps even in my heels, because I don't belong to a gym. So that's my exercise. I keep the yoga mat in my room. It's in front of my bed I have 3-pound weights, 5-pound weights, 7-pound weights, a yoga block, a resistor band. It's all right there, because I guilt myself. If I get into bed without doing something, I feel guilty. So I try to do a little something at night. I'll pull up YouTube videos, because something, even if it's only 10 minutes a day, is better than nothing. And then being extremely intentional about what we choose to fuel our bodies with is really important at this stage. The Mediterranean diet has been shown internationally to be one of the best I'm calling it a diet, but it's really a way of life. But so adhering to the Mediterranean diet can be really helpful. People that adhere to a Mediterranean diet have less cognitive decline. They have less osteoporosis because the foods are rich in calcium, and they have less cardiovascular disease and diabetes. And in particular for us women, it's just a healthier way of maintaining high protein or lean muscle mass too.
Another question with some of the weight loss medications that are out now, do they affect menopause in any way? Since you can get a lot of weight loss, is it a good thing? Are there any contraindications when it comes to that with some of the therapies that one would take for like hormone replacement and things like that?
Yeah, there's some as evidence. I think I shared it on one of the slides earlier that weight loss can help minimize the frequency and severity of hot flashes. I wouldn't say that that's a reason to go on one of those medications, but certainly could. There are lots of other benefits too. Um, I think they work really well when people have already changed their diet and they're already in a good exercise regimen, because even if you just by losing weight doesn't mean that it's healthy. And in fact, if you're losing muscle and those medications, when you lose stuff rapidly, you're losing a lot of muscle tone too. I'm afraid that we're going to see a whole bunch more people with osteoporosis later, not even later in life in a short time, because they're not doing the exercise stuff too. So they work hand in hand.
Oh, another one. This is actually my question.
Okay.
You had mentioned like with the television and stuff on, I literally don't sleep without the white noise. Is that does it have like the same effect, like it's music, or is
Yeah,
it
stuff playing, you hear it, and your brain is thinking about it even when you think that you're asleep. And so it really does impact how deep your sleep is. So I would challenge people not to have the television on in the background at all.
okay. This is also my question.
Okay.
Is it realistic? So say like your mother or your grandmother, their symptoms, they didn't really experience any symptoms in menopause. Is it wishful thinking to think that you may not as well, or is it just
It's hard to say, but you might. Sometimes people do. I even will ask people like, well, how old was your older sister or your mom when they went through menopause? Because sometimes that can help predict when you might go through it. It's not a full say, but I love it. I'm the opposite though. My mom has had a horrible time because I told you I will not say her age. She gets very testy about that. I'm completely the opposite. Like I like getting older. I feel like it's a blessing because I know a lot of people that didn't get to this age. But
right?
yeah, forever my mother was 45, and I would say you should at least be older than your oldest child. And she told me that that was a me problem. She said it sounds like a you problem, not a me problem. But at any rate, she had a very hard time and is still having hot flashes and night sweats. So I feel like that might be my fate. So I'm happy that you have better genetics than I do.
I hope it is my fate. So
Yeah.
fingers crossed. One more question. Oh, it's another one that came through too. So two more questions.
Okay.
Where do you have practice locations? Are you just in Hyde Park or do you
I'm
go?
in Orland Park every Tuesday, but I also do virtual visits too. And menopause consults sometimes lend themselves really well to a virtual visit, especially if you've had your mammogram and your pap smear done with somebody else. And, then, physical exam isn't always as necessary than just talking through your history and what the options are. So I'm in Orland Park on Tuesdays and Hyde Park the other days, but I do virtual visits as well.
Right. Actually, a friend of mine texted me. She said, I wish she was my doctor. And she's out of state. So with the virtual visits, would you be able to do out of state or does it depend?
Yeah, with COVID restrictions lifted now, like, well, no, I shouldn't say restrict, but with COVID, during COVID, we had the option of being able to, as long as you were licensed, we could do visits. And I was doing visits for people all over the place. Now now that restrictions are in place, all of that leeway is gone. You have to be licensed, and I'm not licensed in other states. I'm just licensed in Illinois.
Okay, another one. Mirena IUD. Typically, how long does it take for one to stop having a menstrual period? Is it possible to continue having one using Mirena? I was encouraged to place Mirena and ride the perimenopause wave on through menopause, but I'm still having bleeding 11 months after insertion.
Yeah, typically for most people, they reach, if you're going to be amenorrheic, they reach that by about 3 months. For some people, it is a little bit longer, but what they'll see is that it's at least subsiding. So even if it takes up to 6 months, it's like more just spotting that's a nuisance. If somebody's having still just cyclic bleeding, it's not abnormally heavy or anything, but they're getting a period at about the same time every month, it's still light, it may just be your body is just overpowering it. But if somebody's still getting a really heavy period, you haven't noticed a difference, it makes me think something else is going on. Either the IUD is not sitting in the right place, so we need an ultrasound to make sure it's placed appropriately inside the uterus and not sitting low in the cervix. Do you have fibroids that are, or the biggest one is adenomyosis. And adenomyosis is a condition that affects the muscle wall of the uterus. And hormones, birth control pills, IUD, they don't help. In fact, often people that have pretty severe adeno that continue to have bleeding, they never ever even reach menopause. They continue to bleed. And so they end up needing a hysterectomy. So if you've had an IUD in for 11 months and you're still having heavy or prolonged bleeding, we need to, one, get an ultrasound, an endometrial biopsy is warranted too, checking thyroid hormone because thyroid abnormalities start to rear their ugly head around midlife too. But just making sure that there's not some other reason for the bleeding.
Got it. Another question came through. Feedback. It's the annoying spotting that is ongoing rather.
So, yeah, so if it's just the annoying spotting, it's still kind of long for that, especially if it's more days than not. Sometimes we can manage that if there's just some inflammation of the lining of the uterus with an antibiotic called doxycycline for 10 days. Sometimes that stops it. But I still think I would, just make sure that it's still sitting in the right place and there's not something else going on.
Okay. Another question.
Because it should have stopped by now. By 11 months, that should have stopped. Yeah.
Can multiple and big fibroids cause liver to be enlarged?
And I don't know a mechanism by which the fibroids, but what can happen sometimes when if you're on taking a lot of non-steroidal medication like Tylenol or something to help with pain, that can affect the liver. If you've been on a lot of hormonal birth control to control the bleeding caused by the fibroids, you can get hemangiomas that are in the liver. So I don't know what the finding specific was for the liver findings, but there could be some either from the medications that you've been on to help manage the symptoms.
Got it. So it looks like those are all of the questions that have come through. Great discussion. Thank you so much, Dr.
Great audience.
Yeah. Thank you guys so much for joining.